The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Bradley Ferguson is an assistant research professor in the Department of Health Psychology at the University of Missouri School of Health. Dr. Ferguson primarily studies autism and other neurological disorders. His main research focus is on stress, anxiety, and neurophysiological correlates of gastrointestinal issues in individuals with autism. His goal is to help support appropriate treatments for those with autism to ultimately improve their quality of life. You can type your questions into the question section now and throughout the talk, and he will answer those that he can at the end. I also have posted the handouts into the handouts section, so if you'd like to download those are in PDF format. We'll also send a link out with the follow-up email after the talk. And now I'll turn it over to Dr. Ferguson.
Hey, thanks a lot, Denise, and thanks to ARI for having me. I'm really excited to share these data with you. Today, I'm going to be talking to you about some of the research that I've been conducting in autism, surrounding gastrointestinal problems in autism and problem behaviors, with the hopes to just kind of convince you that GI problems are very important to study in autism, as well as problem behaviors and some possible things that we can do about this. I'm going to be presenting some of the related research around this main study, looking at the GI problem behavior relationship as well, just to kind of get some context. And then hopefully we'll have quite a bit of time for some Q&A, because I always like to get questions from everybody. That really helps me kind of see where I am and get a pulse on how people are feeling about this. So just to start, just my funding sources: Autism Speaks Autism Treatment Network, the Autism Intervention Network, Research Network on Physical Health has funded my research. Department of Defense, as well as the Center for Discovery in upstate New York, has funded some of this research, and I have no other disclosures. Okay, so let's just dive right in. So a lot of us here know that there are a lot of gastrointestinal disorders in autism. One study has found that anywhere between 9 to 91% of individuals with autism experience GI issues. And this wide range is likely due to the fact that a lot of GI assessments are done clinically. So there's no one, typically there's no one questionnaire, standardized questionnaire that's used. This is a large problem in this type of research. But anyway, there's a lot of individuals with autism that have GI issues, and many of these individuals suffer from constipation. So in a lot of my research studies, I talk to the parents while I'm collecting data. I talk to the individuals with autism. A lot of them are reporting constipation. Some are saying that they haven't been able to go to the bathroom for sometimes up to a week, which is obviously a problem. In some of my previous research back in 2017, we use the Rome 3 criteria. So now they have the Rome 4, but the Rome criteria are just agreed upon criteria for different gastrointestinal disorders. So it's standardized, and they have questionnaires. They're very useful. If you're interested in doing this type of research, we can talk afterwards, and I can point you in the right direction for these questionnaires. But using these agreed upon criteria, we found in a sample of 120 individuals that 42.5% met criteria for functional constipation. So what this means, functional constipation, this is constipation that doesn't have, there's no, if you took a tissue sample or something, you wouldn't be able to say, hey, this individual has constipation. This is likely a brain-gut axis phenomenon that's occurring here. And about 12% of those individuals met criteria for irritable bowel syndrome. But still, to this day, we have some ideas as to why individuals with autism tend to have more GI problems, but the etiology, or kind of the course and how this unfolds and why is still fairly unclear. Well, one clue that we have is that there's a lot of individuals with autism that have altered autonomic nervous system functioning. So what this is the part of your nervous system that controls things that you don't think about. So things like breathing and digestion, things of that nature. The autonomic nervous system has two main branches. You have the parasympathetic nervous system and the sympathetic. So the parasympathetic nervous system, this is your rest and digest system. So this is kind of when you're relaxed, kind of hopefully like right now. You know, we're relaxed, we're all at home likely, and this really promotes things like slowing your heartbeat, constricting your pupils. So there's no threat, seemingly. This also stimulates the activity of the intestines, so it gets things moving, if you will. But on the other hand, when we have this fight or flight condition or like a stress response, like let's say you see a tiger, you see a snake, and this is stressful, and so your pupils dilate. They want to ascertain what the threat is. Salivation's increased, heartbeat's increased to get oxygen to spread throughout the body. Airways are relaxed, but also what's really interesting here is that the activity of the intestines is inhibited. And so this could likely be why an individual who has a high stress response, whose sympathetic nervous system is activated, is constipated. It also secretes epinephrine and norepinephrine. These are stress pathways, stress neurotransmitters. And so, again, the fight or flight response, this could be very important in GI problems and autism, especially for constipation. And, you know, really what should happen, or what our body strives for, is for this balance between these two systems. So not too much fight or flight, because then you'd always be using a lot of resources in your body. Well, not too much rest and digest, because then you'd be lazy and something could happen. You may not be able to escape from a threat. And so really what we want, and what is good for the body is more of a balance between these two systems. And what we typically find, not always, but in a lot of individuals with autism, we tend to see more of this. We tend to see more of this sympathetic nervous system activated. And so maybe this has some bearing on why so many individuals with autism have GI problems, and especially for those who have constipation. So this is a little bit of research I've done in the past. We did a study that was funded by Autism Speaks Autism Treatment Network, AIRP, and we wanted to see what happens when you look at the stress response and correlate it with gastrointestinal problems. So very briefly, what we did is we had some mostly children and adolescents with autism. They came into the lab, and they did. We took a cortisol sample. So cortisol, this is a stress hormone. So this tells us, kind of how stressed is this individual. We took it to what we call baseline. So before we did anything, and then we placed their hand in some cold water, which is a reversible stressor, and then we took another cortisol sample. And then what we looked at were their gastrointestinal symptoms. So these are upper gastrointestinal symptoms here. This is their upper GI. So this would be things occurring above the belly button. This is lower. This is really what I'm focusing on here. So this would be things like abdominal pain, constipation. And what we found was there was a positive correlation between their cortisol response and there was a positive correlation between their cortisol response for their lower GI symptoms. So basically, as their cortisol went up from baseline, so did their gastrointestinal, lower gastrointestinal symptoms. And so this kind of says, hey, when you have an individual who has autism, it's very likely that if they have lower GI problems like constipation, their cortisol response to stressor is going to be high, tend to be high. We also looked at these are called cytokines. So these are pro-inflammatory cytokines. We also looked at those and to see if there was a relationship there. With interleukin 6 or IL-6, we didn't find significant correlations here. We did with IQ, which is interesting. I won't be discussing that here, as well as with socialization scores. But we did find some indication that with the upper gastrointestinal disorders, upper GI tract disorders, that we found a positive correlation here. So as the inflammation went up, so did their presence of upper gastrointestinal symptoms. And this can be found here. Here's the actual article. And so we also conducted another study, again funded by Autism Speaks, and we looked at the Psychophysiological Association. So we were looking at heart rate variability. So heart rate variability is a really nice measure of the sympathetic and parasympathetic balances that you can get from electrocardiogram. So just 3 simple stickers on the chest, and you can obtain these data. It's very easy. It's very non-intrusive. Basically what I want you to focus on here is that here on the y-axis we have their lower GI scores. So think of this as largely being their constipation, and as this goes up, so does their constipation symptoms. And then this is their heart rhythm. So this is their heart rate variability here on the x-axis. Now these 2 lines, if the individual did not have a co-occurring anxiety disorder, this is the relationship between their heart rate variability and their GI, lower GI scores. But if they do, this is the slope of the line. And so what does that mean? Well, basically, if you are an individual with autism and you have an anxiety disorder, co-occurring anxiety disorder, that your heart rate variability response to a stressor is going to be much higher. It's going to be altered. And so this places these individuals more at risk. Basically, if you have an anxiety disorder, it's likely going to increase the impact of these GI symptoms that you have. And then same thing, very similar. These look very similar, but they're a little bit different. So this is for regression or loss of skills. So these are individuals that maybe previously had language and then lost it. Same story here. If you have regressive autism, you tend to see an altered GI heart rate variability relationship. And so what this says, what the take-home message is from this, is that that the presence of a co-occurring anxiety disorder or regression or loss of skills in autism, it alters the lower GI tract parasympathetic nervous system relationship. And so alterations in sympathetic and parasympathetic functioning in the body are associated with GI symptoms. And so then that brings me to the whole reason I was invited here to ARI to give this webinar. That was some background information. This is the current study I'm going to be talking about. It was published in Frontiers in Psychiatry about a year ago or so, April 9th, and this is open access, so you can Google this and you can find it very easily. It's free to read. So in this study, we wanted to, let me go back. So we wanted to look at the relationship among GI symptoms and problem behaviors and internalizing symptoms. So what this means is things like anxiety and depression, things of that nature in children and adolescents with autism. And so the participants from this study, we had 340 children and adolescents with ASD. All these diagnoses were confirmed using the ADIR or the ADOS. These were clinic patients at the Thompson Center for Autism and Neurodevelopmental Disorders here at the University of Missouri in Columbia, Missouri. And the sample consisted of individuals with autism aged 2 to 18 years of age, a mean of about 5.5 years of age. And so the measures that we gave, or the measures that were collected rather, the caregivers completed a dietary problems scale. So we wanted to know if diet had any impact on these GI symptoms. Was it associated? Also nutritional problems. So the question was, is the child's nutrition adequate? Current GI symptoms. So this is just presence. So constipation, diarrhea, nausea, vomiting, or stomach aches. And then for the internalizing and externalizing symptoms assessment, we use the child behavior checklist that many are probably familiar with. And these are asking questions on, again, mood and things like anxiety, depression, and externalizing symptoms like problem behaviors like acting out, being aggressive, things of that nature. And so the parents filled these out. And so for the statistics, we use correlations. So again, there's no causation. We cannot derive causation from this. This is all associations. And we divided the sample into 2 age groups. So we have a younger group, so 2 to 5 years of age, and then an older age group, the 6 to 18 years of age. We did separate logistic regressions for each of the 4 GI symptoms as outcome variables for each group. And then again, those predictors of interests were internalizing and externalizing subscales from the child behavior checklist. And again, we created those 2 groups, 2 to 5 and 6 to 18. So I'll refer to them as the younger and the older group. So here are some descriptive statistics. So we had 200 individuals in that 2 to 5 years of age group, and then 140 in the older group. The IQs were not different. However, the younger group reported more dietary problems. There was a significant difference between the number of dietary problems reported for the younger group relative to the older group. Otherwise, they were similar. And so here are some of the actual results that we got. So for both groups, so this is considering both the younger and the older groups, 65% of these individuals experienced constipation, 50% stomach aches or stomach pain, 29% diarrhea, 23% nausea. And what was interesting to me is that 93% of this sample, they're not taking any GI medications. So, for example, one of the things that people take for constipation is Miralax. So a lot of these individuals are suffering. They are having a lot of pain due to these gastrointestinal disorders and symptoms that they're having. And furthermore, what's interesting is that half of them, a little over half, were taking medications for other reasons, so like ADHD, aggression seizures. So what that says is that these aren't individuals in this group. These are not individuals that are opposed to taking medications. These are individuals that are they're not taking GI medications because they may be trying other things. They may be trying some altered diets. They may be trying some more natural approaches. It's not known. But regardless, this is a very large number and really speaks to the fact that we need to get these individuals the help that they need. So looking at the younger groups, so that 2 to 5 years of age, so we wanted to know, do GI symptoms predict internalizing or externalizing symptoms? And what we found is that if an individual experienced nausea, they were significantly more likely to have aggression. So this is aggressive behavior. And that could be defined as really anything. It's up to the parent as far. So it could be anything from throwing things to hitting people, so things of that nature. And that's all that we found there for the younger group. Now with the older group, we found some more complex relationships here. So again, same question, 6 to 18 years of age, but do internalizing or externalizing symptoms predict the GI symptoms? So for anxiety, if the individual had anxiety, they were 11% more likely to have constipation, with 9% less likely to have stomach aches. If they had withdrawn behavior, so this is kind of wanting to be by themselves, not really wanting to be around others, they were 11% more likely to experience stomach aches, but 9% less likely to experience constipation. And if they had greater somatic complaints, so this may be kind of like pain, not feeling well, they were 11% more likely to experience nausea and 11.5% more likely to experience stomach aches. So really what it seems is that the younger kids, let me go back, the younger kids, they're acting out more with aggression, and that kind of makes sense. They're not necessarily experiencing, the withdrawn behavior and anxiety, but they're acting out with more aggression. Whereas the older individuals, they're having more internalizing symptoms, so like anxiety and withdrawn behavior. And furthermore, this is compounded by an individual. This is compounded when an individual is also either nonverbal or minimally verbal, and so you can kind of see how this kind of plays out. You have an individual who's minimally verbal or nonverbal. They're experiencing gastrointestinal pain. Let's just say it's constipation, and this it hurts, and they're not able to say, "Hey, this really hurts me. I'm experiencing pain. I need help." And the way that they portray that is likely in the younger kids, it's aggressive behavior, and in the older individuals, it's more internalizing. So again, with this, the majority of the participants reported constipation. So this corroborates previous research that we've done here at the University of Missouri Thompson Center. And again, the young children with ASD, they're nonverbal. They may use aggression to communicate their somatic complaints. And so this really highlights the reason, or one reason why we really need to address these GI problems in this population. You may be able to knock out the GI problems, and then at the same time address problem behaviors. And that's a very positive thing if we can do that. So again, the older children and adolescents, they have more internalizing behaviors associated with GI symptoms, the anxiety and the constipation, and the withdrawal and depressed and increased stomach aches with decreased constipation. And again, even for the older kids, same thing. The GI disorders and behavior problems are related in ASD. They may serve a communicative function of discomfort. So switching gears here, I kind of want to talk about another study that I've done, and this is a totally different population of individuals with autism. So this study, again, it's published in Frontiers in Psychiatry in September of last year. And this is open access, so you can go online and view this. It's not behind a paywall. And what we did here is this is a collaboration that we have with the Center for Discovery, and they are located in upstate New York. They're a wonderful residential center for people with disabilities, especially individuals with autism who need a lot of support. And what we looked at here was the association between electrodermal activity. So what this is we're measuring skin sweat. So when you sweat, that's an indicator that you're stressed. And so as that goes up, so does stress and problem behavior. So what happens when you measure this electrodermal activity? Can we predict problem behaviors? And this is in severe autism. So what that means is all of these individuals are nonverbal, and I'll get into that here in a second. Nonverbal and fairly low IQ, and so they're not able to tell you when they are becoming frustrated or having pain due to gastrointestinal problems. So this is a small study. Again, this is a feasibility study that we wanted to do to see if we could even get these data from these individuals. As you can imagine, you have a lot of movement in kids in general, and then when you have an individual who's fairly low functioning, they are likely not able to, or oftentimes not able to follow instructions. And so just things like keeping the wrist monitor on, and I'll show you what that looks like here in a second. So again, this is in 8 individuals. Here are the ages of these individuals. So these are mostly, upper teenagers, all male. So that is one caveat of this, is that this is in all males. And then IQ, so if we look at IQ, average IQ is 100, these are low, and a lot of these, the NSs, we're not able to get an IQ. So very low functioning. Now, what I want you to pay attention to here is that the co-occurring conditions in these individuals. So you have constipation, vomiting, constipation, GERD. Only 2 of these individuals did not have gastrointestinal disorders. And so although we didn't look specifically at the GI electrodermal relationship in this study, it is very interesting, and it supports kind of what we're looking at here, is that there's an altered stress response here in these individuals with autism that's associated with GI problems. So the basic premise of the study is that these individuals, so they are living at this facility, but this is class time, so they're in a classroom setting. They have a teacher here who's teaching some lessons and things, and you have a helper, you have some residents, and what's happening is that this individual here, you can see it. This is on his left arm here. I hope you can see my mouse pointing. There's a sweat monitor. And so this has 2 little pads on the bottom, and they can detect when this individual is sweating. We also have cameras set up around the room, so they're watching these behaviors. And then offline, the staff there at the Center for Discovery, they are telling us exactly at what point in time a problem behavior occurs. So in this particular example, you can tell this individual's he's quite upset, and we have the permission of all the parents and everyone to use this image. This individual is very upset, just jumping in his chair. And let's look at his electrodermal activity. So this is what we call baselines. This is kind of, before you've asked them to do anything, just kind of sitting there. And so again, this is their skin sweat. So the lower the sweat, the lower the stress typically. And this is what we see, very calm, just kind of relaxed. And then what we have here is what we call this anticipatory rise. So this is when this individual is starting to get upset. They have not engaged in problem behavior yet, but they're becoming upset. And then finally, this image was taken kind of where this black bar is, and this arrow right here indicates when the problem behavior began. So this is when this individual first started jumping up and down in their chair and becoming very frustrated. And so what's interesting about this is that we have the technology now to be able to look at this anticipatory rise and intervene before this problem behavior occurs. And so in the study, what we found in the 8 individuals is that rise in skin conductance. So again, this part right here, this rise occurred 60% of the time prior to the problem behavior. So what does that mean? These individuals were becoming stressed before their problem behavior occurred over half the time. Furthermore, their skin conductance returned back to that normal level. So it went back to this level less than half the time. So what that means is that after an individual engaged in problem behavior and their skin conductance went way up, it didn't get back to normal levels, but only 45% of the time. So this means that anything that you're probably trying to do after that problem behavior, and this is not surprising, anything you're trying to do after that problem behavior is going to be coded by this stress response. It's going to be very difficult to kind of get back to your lesson and skill teaching or whatever you're trying to do and whatever they're trying to do with their lives. Now, this is what's most striking to me, and this is where we can intervene. And so the average rise in skin conductance before the problem behavior. So again, the average amount of time before we get to this point is about 10 minutes. And to me, that is very significant. That means that we have plenty of time to intervene before these problem behaviors occur. And so this is one line of research. We're not the only ones out there that are doing things like this, but there are a lot of teams out there that are doing this, trying to look at this skin conductance, heart rate variability, other physiological measures that are relatively non-invasive, things like wearables. You have your Fitbits and things of that nature, and they're looking at these data to see if we can use them to understand when an individual with autism is going to likely have a problem behavior. Because these kiddos, they can't tell you. This individual, it's nonverbal, can't tell you when he's becoming upset, but he clearly was. And so again, there is this relationship here between the stress response and problem behavior in this population, and we can intervene. And I really hope that this research continues to develop, because I think it is just so incredibly important to help increase the quality of life for everyone. All right, so I'm going to shift gears again. So what can we do about it? So I am involved in a few clinical trials. One of them is looking at this drug called propranolol. And I've been doing research in this for 10 years, and my collaborator, Dr. David Beversdorf, who's a physician, he's been doing this research in autism for about 20 years. And we finally got to the point where we were able to do a clinical trial of this drug relative to placebo in autism. And we're looking at its effects on core ASD symptoms, language, but we're also looking at GI symptoms. And these are some very preliminary data. So in that clinical trial that I just mentioned, that's a 12-week clinical trial, and it's still blinded because we are still collecting data. So I don't know what drug they're taking. The patient doesn't know what drug they're taking, if it's propranolol or placebo. However, at the end of the study, at the end of the blinded portion of the clinical trial, the family has an opportunity to participate in what's called an open label extension. So this is a study where we're actually giving them the drug. They know they're taking propranolol. We know they're taking propranolol. So that is one of the weaknesses of this, is there could be, an expectancy effect. However, these are the data that we have now at this point. So what this looks like is that we take their anxiety. So this is what we call a clinical global impression of severity. So this is kind of the physician, the lead PI, David Beversdorf. He'll talk to the parent and kind of ascertain what their child's anxiety level is at baseline. So this black bar, this is their anxiety level at baseline before they've taken the propranolol for this open label extension portion. They go home, they take the propranolol for 12 weeks, they come back, and then they give us another anxiety rating. And as you can see, these bars are quite different. It's a little bit, this difference is significant. So anxiety levels are going down for these individuals. This is in 6 patients so far. We have some more data, but this is what I had available for presentation today. But this is looking very promising. So basically what this is saying is that after 12 weeks of taking propranolol, these individuals are experiencing lower levels of anxiety, and that makes sense. Propranolol, just to back up here, propranolol, this is a drug that was developed and FDA approved originally for the treatment of heart rate, high heart rate and blood pressure. And so, but it also has anxiety blocking properties. So you give this drug and you show somebody a snake that they're normally afraid of, they won't be afraid of it. So also people with test taking anxiety take this and have really good results. Same thing with people that are performing and doing things like musical performances or singing, as well as people who are public speaking like I'm doing today. It can be very stressful for some. And so taking this drug helps them. And so anyhow, we also are looking at constipation, how this drug, so what happens when you block the stress response of constipation. And so these are some, just again, preliminary data from individuals who had constipation at baseline. We're seeing a reduction in constipation after 12 weeks of administration of propranolol. However, this difference is not significant at this point. This is what we would call trending. So it's going in the right direction, but it's not significant yet. But however, there are some reductions in constipation, and while this may not be statistically significant, it could be clinically significant and have some really nice implications for future treatments. But again, I do want to express that I'm not a physician. I'm not recommending this at all. I'm just presenting the data to you so that I can tell you kind of what's going on in the science and how we're trying to find treatments. But at this time, this is not approved. This drug is not approved for the treatment of this. And any treatment decisions should be made in conjunction with your treatment team, including a physician. Okay. One other study I want to show you that we've submitted for review. So this has not been accepted by a journal yet. It's under peer review. And we looked at the effects of propranolol on the relationship between GI, gastrointestinal, and amygdalar reactivity. So this is a region of the brain that lights up when an individual is stressed, or, again, they see that snake, they see that tiger. This area of the brain becomes very active. It helps to kind of encode things to memory, to say, hey, next time you see that big slithery thing coming your way, you should probably get out of its way because it might hurt you. But this is true for other things too, like, again, public speaking, or in autism, you have individuals who they don't like social gatherings, or the things of that nature. So in this study, we have 12 individuals. So again, highly male. It's not surprising. I wish we could bump this up, but we always try to get as many females in our groups as we can. Full scale IQ of 80 or above, and these individuals attended 3 sessions. So one session they came in, they took a placebo. One they came in, they took nadolol, and one they came in and took propranolol. Now, these 2 drugs are very similar. The only difference is that propranolol is able to cross the blood-brain barrier. So this drug acts all throughout the body in addition to the brain and the spinal cord. Nadolol, it's the same thing, except it does not cross into the central nervous system. So this does not go into the brain. It just stays peripherally throughout the body, but not in the brain. And so what's nice about these 2 is that you're kind of able to make some, you're able to kind of tease apart if the finding that you're seeing is due to likely a peripheral effect or a peripheral and a central effect. So we also administered this GI questionnaire. So this is the Autism Treatment Network GI Symptoms Inventory, or the GISI. And this screens for abdominal pain, nausea, diarrhea, and other GI symptoms. Okay, so how did we get at the amygdala? Because this is in the brain. Well, we did functional magnetic resonance imaging. And so the setup here is that the individual was in an MRI. They were looking at some emotional faces on a screen while we were looking at their brain activity, and specifically focusing on their amygdalar reactivity. We showed them some angry, some afraid faces, and some neutral faces, and this is what the tasks look like. So basically, their job is to look at these faces and press one button if this face matches or if this face matches. And we're not really interested in how well they match. We just want them to look at the faces. And these faces have been shown, and even in people without autism, to activate the amygdala. So this is a task that activates the fear area of the brain. But it's also been shown to activate, the same task has been shown to activate the amygdala in autism. And it's correlated with social anxiety. So we're activating the amygdala, and we're trying to see what the effects of these drugs are on that amygdala-GI relationship. Okay, so let me go through these really quick. So this panel is with placebo, this panel is nadolol, and this one is propranolol. Okay, and what we're looking at here is this change in amygdalar reactivity. So basically, as this goes up, their amygdala is becoming more active relative to a neutral condition or a neutral phase. And this is their GI symptom score. So as this one goes up, as this side goes up, their amygdala is becoming more active, more stress. As this goes up, more GI symptoms. And so in this condition, they're on a placebo, and you can see there is a statistically significant relationship between these two variables, so such that, and it's a positive relationship. So as their GI symptoms go up, so does their amygdala reactivity, meaning more stress. Okay, so placebo is not doing anything to this relationship necessarily. It's not doing anything. All right, so then we get down to the nadolol. It's a very similar thing. The slope is a little different than this one, but again, there's still a positive relationship here between their GI symptoms and their amygdala reactivity. But then you get over here to propranolol, and this is what I think is very interesting for the purposes of treating GI symptoms which may impact problem behaviors. This is very different. This line is quite flat. It's not entirely flat, but it's flat. When you administer the propranolol, there is no relationship between their GI symptoms and amygdala reactivity. So this begins to suggest that perhaps the GI stress relationship is likely related to something that's going on in the central nervous system. So again, this nadolol doesn't cross over into the brain. You don't see that effect, but this one does, and you see the effect. And so this is very promising to me. I don't know where this is going to lead. Again, this is in a small number of individuals, and so we need more research, and we're following up on this. But it is a starting point. It kind of begins to suggest maybe some types of pharmacological treatments that may treat GI problems and autism, which then may help out with some of the problem behaviors. Okay. One last thing here. I work on a really, brilliant team. There's a lot of really awesome, really smart people that I work with, and I'm so privileged and I'm so happy to work with these individuals. And right now, our team at the University of Missouri is collaborating with Pittsburgh, University of Pittsburgh, as well as the University of Florida. And we are, I would say, kind of in the final stages of obtaining some funding to look at what's called transcutaneous vagus nerve stimulation, or TVNS, in autism. And what this is you have this small device that can fit in the ear, and it's a stimulator, and so you can't really feel it. You may feel a little tingle, but largely you don't feel it. There is a branch of the vagus nerve. So the vagus nerve is the parasympathetic nerve. So this is, again, if you remember from earlier, this is that rest and digest nerve. So when this thing is active, it's really trying to promote rest and digest, calm down, homeostasis condition in the body. Okay, and typically you need to get into the brain to stimulate this thing. So that's obviously very invasive. It's neurosurgery. We don't want to do that unless we have to, but we don't want to do that. And so what's really nice about this TVNS is that you are able to place this little electrode here into the ear, and it's removable. Kind of looks like an earbud. There's different ones. You can do one here as well. And the auricular branch of this vagus nerve projects to this area inside the ear. So basically, you stimulate this part of the ear, you activate the parasympathetic, the vagus nerve, which is parasympathetic, and it can cause a lot of these target organs like the stomach and the heart, the liver, the pancreas, the gut, to rest and digest, to calm down. And so this is not a pharmacological treatment like this propranolol. Currently, this is our model. As we're looking at propranolol, we're trying to block the sympathetic hyperarousal and look at the effects on social interaction, language, adaptive functioning, and GI problems. But what if you're able to look at this vagus nerve stimulation and actually upregulate this nerve? So actually stimulate this thing. The propranolol, this is blocking it. So this is assuming that you have a high stress response and you're trying to block it. This TVNS that we're looking at, this can actually modulate this by upregulating parasympathetic. So you're basically turning this thing on and looking and dampening the activity of these organs and trying to see what the effects are on core ASD symptoms and things of that nature. So this is one thing that we are looking into. We haven't started the study yet, but I think this is very promising, and this is kind of the area of the research that we're doing in humans to try and address these issues of GI problems and problem behaviors. Okay, so the take-home messages. GI symptoms, they're common in ASD, especially constipation. They're associated with an enhanced stress response, particularly for things like constipation. GI symptoms are associated with internalizing symptoms and problem behavior, but this may differ by age. So again, the younger kids, they tend to engage in more aggressive behaviors, whereas the older individuals, they're more internalizing, so things like withdrawn behavior, somatic complaints, and anxiety. The stress response, it may precede the problem behavior in ASD. So again, this is an area where we can begin to interact and perhaps intervene to prevent this from happening. And some potential treatments may involve reducing the stress response. So it could be that pharmacological propranolol, could be vagal nerve stimulation, or behavioral. You could have maybe doing some yoga or doing some type of breathing exercises. Those things may work, but we don't know. But more research is needed in this area. And that's all I have. I want to thank everyone at the Thompson Center and their patients and their families for allowing us to collect the data from them. Dave Beversdorf, Chris Dovgan, and Nicole Takahashi, all very key in these studies, as well as the Department of Defense for funding, as well as the Center for Discovery and Autism Treatment Network for their support. And I'm happy to take any questions. Thank you.
So we have quite a few questions here, and everybody who's on the line, we've got another few minutes. So if you've got some questions, type them into the question section and I can read them to them, and we'll get to as many as we can. As probably is always the case, one of the main questions I got is, how do we enroll in studies? And does Dr. Beversdorf see patients there at the clinic? So,
so if you are interested in this particular propranolol trial, that is, it's open to anyone, but obviously there are, anyone is in, if you're anywhere and you meet study criteria, you participate, but there's also some travel logistics, and especially right now in these times, we've actually gone to complete Zoom meetings, if you will, for these visits. So we have a lot of people who are actively taking the drug, but we're seeing them now through Zoom and not getting some of our physiological measures. If you want to participate in these studies, you can look at clinicaltrials.gov, and Denise, I can send you the link to this if parents and all are interested in participating in this individual trial. But clinicaltrials.gov, I think, is a really good spot to look at. These are very legit clinical trials. They're going to be, funded, and they're legit. So I think that's the best way.
Okay, and then the other part of that question was, does Dr. Beversdorf see patients there at the clinic?
Yes. Dr. Beversdorf sees patients at the Thompson Center for Autism. I can't speak for him as far as his schedule and all, but yes, he does see patients there, and is continuing to see patients even through this COVID-19.
Another question about propranolol was about side effects. So you talked quite a bit about you just were able to touch on what you observed in terms of the study, but were side effects, were they evaluated at all, or are there standard side effects that are observed?
So we screen the patients for the clinical trial very thoroughly. One of the contraindications for this is if you have asthma. So this drug, if you take it and you were to have an asthma attack, your inhaler may not work as well. So we exclude those folks from the study. So if you have asthma, it's not safe to participate, so we don't include those individuals. And as far as side effects in the study, this drug slows your heart rate and blood pressure. So that's another one. If you have slowed heart rate and blood pressure or lower blood pressure, it's not recommended that you take this drug because it will lower it even further. So again, we screen for that criteria and don't include those individuals. But as far as side effects in the study with the people who are taking propranolol, we haven't had anything strange or anything. It's mostly tolerated. Sometimes it will make some kids sleepy. So for those individuals, if it makes them sleepy, we can adjust their dosage to a different part of the day. But largely, we're having some people are getting better. Again, we don't know if they're taking placebo or propranolol, but we will have the results of this study this fall. I'm thinking around maybe October, November, somewhere in there, and we will publish them we will submit them for peer review as soon as we have them.
This next question is about nausea. So you described assessing nausea in the patients with the young children. So how did you assess that in younger kids?
That's a really great question, and it kind of speaks to one of the problems of doing GI research in autism, especially in younger populations. And these could be things from the child just kind of maybe grabbing their stomach, not feeling well, maybe some vomiting involved as well. But yeah, it's kind of murky waters, if you will, there. And that's why I really think that with these kids, they need a thorough GI workup to figure out really what's going on. And a lot of these kids, they don't have it. I'm not a gastroenterologist. I have friends that are, and they do wonderful work. But I still think we need more. I think that these GI problems need to be considered more than just phenotype. This is just involved in autism. It's a GI problem. And do more treatments and things to help, especially given their relationship with problem behavior and decreased quality of life. But no, that's a great question.
So in terms of GI problems, did any of these studies look at diet closely? It looked like the first study did that you brought up. And were there any findings specific to special diets or other strategies that families use?
That's another great question. So I didn't include the data here, but there's another publication out there from our group where we looked at the association between gastrointestinal disorders and diet. So we have a questionnaire where we looked at, or we asked the parents and some of the individuals who were older with autism what they ate over, a few weeks' time. And then we went into, so let's say that they ate chicken nuggets. So then we went on to the USDA, they have a really nice website where you can get all the micro and macronutrients and things of that nature, and then correlated each one with their GI symptoms. We didn't find any relationships. This is including gluten and casein. I didn't present those data today, so I was trying to not include too much, but the paper is out there, and the short answer is no, we did not find a relationship between diet and GI symptoms.
So generally you'd say, though, based on what the studies that you've done, diet aside, that there definitely is a direct correlation between these GI symptoms and there can be behavioral improvement when they're appropriately addressed.
Yes, and generally speaking, yes. But again, excuse me, the studies that we've done have largely been correlational, and so we can't say that the GI problems are causing the problem behavior. The problem behavior is causing the GI symptoms. And I've thought a lot about this, and I think there's some face validity to saying that the gastrointestinal disorder is likely related to the problem behavior. But again, we don't know for sure. But I think that any type of treatment that's aimed at either of those two is going to be beneficial to everyone. And so, whether that be, more behavioral type therapy, I guess that's one study you could do, is address, excuse me, address the problem behavior, through some behavioral interventions and see if there's GI problems. We're going at it from the other angle of treating the GI problems, or looking at treatments of GI problems to see how they affect problem behavior.
Okay, so the study where you broke them into the groups had the younger group and then the older group, and it cut off, I believe, at age 18.
Correct.
So people were asking about, could you still generalize out from that about adults, or do you feel like an adult study is something that needs to be tackled separately?
I definitely believe that we need to do adults separately. Kids are not just younger adults, and adults are not. They're their own population, and I think that there is a very there's not a lot of research out there in that population. And so, yes, I don't think that we can necessarily extrapolate to these findings to older adults. And so that's an area of research that we need to look at.
So if a patient came, did you have any participants in these studies who seemed asymptomatic, so they weren't actually displaying any symptoms of GI pain directly, but that you later determined had suffered constipation or other GI symptoms?
Yes, there's been some of those. And really what happens is that they don't realize, some individuals with autism, they've been living with this for so long, it seems, and these are just my thoughts, take them as you will, but my impression is that they've been living with these GI problems for so long, they're desensitized to the pain, and they don't really realize it until you give them a questionnaire about these things, and they go, oh my gosh, I have these problems. I don't go to the bathroom, but every maybe 4 or 5 days, and it hurts, but I just kind of deal with it. Or maybe they don't realize it hurts. And so I've seen a lot of that, and we're not quite sure what to make of that. It could be, a central nervous system thing where there's been so much pain over the years that the brain has just kind of shut it off and said, hey, don't pay attention to that, and they just deal with it. Or it could be something in what we call the enteric nervous system. Excuse me. This is a nervous system that's housed inside of your GI tract that may not be functioning properly. We don't know.
Okay. So the age groups that you broke those participants into, why was the age cut off the way they were? So I believe it was like 1 to 5 or 2 to 5, and then 6 to 18. Is that right?
Yeah, 2 to 5 and 6 to 18. And really the reason why is because of that's the way that the CBCL breaks down the age groups. And so we thought, this is kind of a good way to do it. We want to look at the young and the old. Sometimes some of these studies will look at all of them kind of combined, and we wanted to at least have an attempt here to look at the younger and older populations to see if there were differences, and of course there were in the problem behaviors that we saw. The younger kids were more aggressive than the other ones. The olders were more internalizing symptoms.
All right, we have time for just a couple more questions. I'm going to squeeze a couple more in. So
Great.
This one, they're asking about that same study, I think, and other studies as well. Did you sort out patients who had fetal alcohol syndrome or Downs or any other comorbidities?
Well, that's a great question. And yes, we did. Those were not included in the study. So we have, for the sake of time, I omitted all the nitty-gritty details, but you can read about them in the paper. Again, they are open access. If you don't have access through university or something, anybody can. Anybody right now can go on and look at it. Those groups were excluded, so we really wanted to look at individuals who had autism. There's a lot of co-occurring conditions, as you might expect, things like ADHD, and you can't get around that, or else you won't have people that you collected data from. If you exclude that, it'll be very difficult. So, but yeah, with the more complex things like fetal alcohol syndrome and trisomy 21, those are not included.
All right. So one more question. So this person is asking about blood tests for GI problems. Did you use any blood tests in the studies that were specific for that?
We did not, and that would be great. That is an excellent question, and I really hope that we can get to trying to find to that someday. But the short answer is no. However, we looked at these things that are related to the stress response. So like cortisol, these were from blood, and I typically I really try to get around doing blood in these studies if I can, especially for the younger kids, because they just don't like it. I don't like having my blood taken. I can only imagine what a kid feels like. So no. But again, we do from time to time look at these blood markers, like I said, these inflammatory cytokines, and we found this relationship with upper GI symptoms. So these are GI symptoms occurring above the belly button, and they were positively associated with inflammation, but not for the lower. And there's one kind of reason why this may be. An individual who has this cortisol response over time, this kind of shuts down the immune response. So it kind of speaks to like when you're really stressed, you're more susceptible to getting sick, and this is one of the mechanisms for that. But yeah, again, to answer the question, no, we haven't found a blood test yet to do this. Typically, these kids are going to have they'll be scoped, they'll have a formal GI evaluation, and that's the way to do it. But there's no blood test yet.